Hello, I'm Deborah Chieli, a nationally board certified nurse practitioner with specialty certification in lifestyle medicine.
And I'm Susie Spell, a nationally board certified nurse practitioner, also certified in lifestyle medicine.
The following interview was part of a series that informed our presentation at the 2023 Annual Conference of the American College of Lifestyle Medicine, ACLM, titled Nurses in Action, How Nurses Operationalize Lifestyle Medicine in Modern Settings, and You Can Too.
In this series, nurses from diverse backgrounds and practice settings and their champions tell their personal and professional stories about discovering lifestyle medicine and how they're implementing it across a wide range of settings.
Nurses are the largest health profession in the United States and globally, and have been voted the most trusted profession here in the U.S. for over 20 years. Learning about and incorporating the pillars of lifestyle medicine fosters full scope of practice and the ability to answer the call to lead by the National Academy of Medicine with their report, Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity.
We hope these stories of success will inspire conversation and drive creative solutions to better address inequities in healthcare. Continued growth of nursing expertise in lifestyle medicine will expedite our nation's ability to address the public health emergency of chronic lifestyle diseases we currently face.
The power of nurses to create innovative solutions when combined with the practice of lifestyle medicine allows nurses to express their full potential while simultaneously addressing the salient issues of health equity, the epidemic of chronic disease, and the provision of truly patient-centered whole-person care.
When nurses are empowered to lead with an interdisciplinary and multi-sector practice, they answer the call of the National Academy of Medicine to dissolve barriers to care and improve health for themselves, the nation, and every global citizen. Enjoy the interview.
Good morning, Maryta. Marzano. It's so beautiful to be with you here this morning for this conversation. I want to thank you for allowing us to have this wonderful chat. And just to introduce you to everyone, you are a family nurse practitioner. You're working in the preventive medicine, lifestyle medicine office at Stony Brook University. You're also a PhD candidate doing a lifestyle medicine dissertation. You just finished a scoping review on nurse-led models of care for the prevention and treatment of bed embolic syndrome, which was accepted to the Journal of Clinical Nursing. You are working with Stony Brook School of Nursing to build a lifestyle medicine interest group and take 2 students per semester into your lifestyle medicine office. And clinically, you're in the, along with your team, you're in the process of restarting group visits and quarterly workshops for lifestyle interventions. And your career goals are to further develop lifestyle medicine for nurses in both curriculum and practice. Wow.
Yes.
It's so thrilling. It's such an honor to be with you here today. Thank you.
Thank you. Same for me. I'm so happy to be here.
Thank you. Well, let's begin. So I guess, can we start a little bit with your origin story? How did you begin this journey as a nurse and your journey in lifestyle medicine, lifestyle nursing?
Yeah. So working as a nurse, I saw firsthand the effects of what a poor lifestyle does to a person's physical health. I at first knew that I never wanted to suffer with these kind of preventable illnesses. And so as my career advanced, I learned that most people didn't understand that many of these things were preventable. So I wanted to share that with the public so that they knew that they didn't have to suffer this way. There was a way to prevent these things from happening.
What gave you that insight that as a nurse, you saw the end result of that, but where did that come from? What informed you?
It was very specifically when I began working as a nurse practitioner that my patients that had type 2 diabetes felt that this was something that just happened to them. And type 2 diabetes is preventable. It's not something that just happens to you. It's a result of your diet and your lifestyle. And when I tried to share this with them, it was really trying to change a culture and having them to understand that they can do things that will take this disease away from them. So that was very enlightening to me and frightening at the same time. I wanted to fix that.
Mm-hmm. So their whole idea and that whole culture is, well, it just happened to me, or it's in my genes, it's in my family. You realize that you were literally trying to shift an entire culture when you're giving them that information. Can I ask you also about your education, some things that might have been unique to that supported your understanding and insight into this as a lifestyle disease?
So I came across lifestyle medicine when I started working on my PhD. When I started working on my PhD, I knew that I was more into health promotion and prevention. And I knew that I was more into a natural and holistic version of doing that. And I actually stumbled across lifestyle medicine on accident when I was doing my research. And when I found it, it was like this light bulb went off. Like, this is what I'm trying to do. This is exactly what I believe and what I'm trying to do. And so I quickly became a member and jumped in with both feet to try to spread this out as far as I could.
Hopefully one day, I know your vision is going to be that we're not in a position where you have to stumble on it, that you actually are, that's part of your education and your experience, rather than, oh my gosh, how did I come to find this? And yes, it's a sad statement yet, and yet it's so exciting to know that you're able to come upon this and it's really codified as a science with so many resources that when one does, and one day we won't have to stumble upon it, future nurses won't, but that here it all is so much built out for us. And so can you tell us a little bit about, I know we want to dig in on what you're doing with your dissertation and the clinic there, but can you tell us a little bit about how you're practicing right now, how you work as an advanced practice provider there in that amazing clinic?
Yeah. So our clinic is a lifestyle medicine clinic, but we operate as a primary care office. So our patients are just like-minded like us, and they prefer a lifestyle approach to their care and their prevention. So all of our visits do touch on their lifestyles. So if you're here for a generalized follow-up visit, we are going to go over your sleep patterns. We're going to talk about your exercise regimen. We are going to talk very much in detail about your diet. So I like to do something called a 24-hour food recall. So I know exactly what you're eating. If you come in with a complaint, we tend to address the lifestyle things that you can do to fix that complaint. So if you are there with anxiety, we're going to talk about meditation and mindfulness as well as exercise. And so we tend to use things like that as our primary go-to for fixing things and preventing things. Mm-hmm. And we have a lifestyle medicine website for Stony Brook that is very helpful and has a lot of resources on it. So anything that we run out of time for, we're able to share with our patients where they can find additional resources.
Wonderful. Is that also open to others to check out?
Yeah, Stony Brook. If you just Google Stony Brook lifestyle medicine, it'll come right up. It's the first thing.
Wonderful. Can you tell us just briefly about the background of the clinic itself, the history there?
Yeah, so the clinic is part of the preventive medicine division of Stony Brook Family Medicine. And Dr. Raja Jaber is the one that started it all. She's the one that is responsible for the website with all of the information. She has always been like a holistic kind of practitioner, and she really spends a lot of time with her patients and has advocated for the office to maintain its lifestyle medicine approach so that we have 40-minute appointments instead of your standard 15-minute appointments. That's been like pretty big for us to be able to maintain that.
Who are your clients?
So our clients are just regular people in the community. They're the public. One of the things that I think is really beautiful about our office is that we operate on insurance. There's a lot of lifestyle and a lot of wellness clinics that are private and they don't take a lot of insurance, but we operate on insurance. And I think that that's a really beautiful thing that we give to the community around us, is that no matter where you come from, we try to work with you.
Wonderful. That, Maryta, is a really big issue for nurses, as you know, is oftentimes nurses are considered a cost rather than able to bill for their time. And then even at the provider level, the ability to remain solvent with the reimbursement codes as they are, and yet dedicate 40 minutes. Can you tell us a little bit about how you're able to do that?
So right now we actually operate in a deficit. Us being a part of a large academic institution, I think that's what allows us to do that for right now. But we are trying to get group visits back up and running, because group visits is really how we fight that deficit. But group visits right now for us are a space issue and a staffing issue, because the patient still needs to be brought in and triaged by a nurse. And so we're working through some of those kinks. And COVID, I think, is the reason that the group visits initially went away in this office. And so we're kind of trying to get everything back together again so that we can bring them back, and that will take us out of our deficit.
Can you tell us a little bit about your team there when you speak about your nurses and the triage, and what type of, does it begin there, how you're working with your nurses and as an integrated lifestyle medicine team?
Yeah, so it's me and two other physicians. So it's one nurse practitioner and two physicians that are the providers in the office. We have two nurses, two licensed practical nurses that help us as well. And then we have two medical assistants. So we're a fairly small practice, and it can, when you look at the grand scheme of our large academic institution, but we have a nice little team that we all kind of work together. And the nurses have been there for a long time, so they are very knowledgeable in how we practice and how we treat our patients.
Are you utilizing them in a way beyond the triage and that, in terms of, say, follow-up calls or some of the other things that might be possible with BSN RNs or MSAs or some of the other chronic care models with insurance and that?
We're not right now. We have been throwing around the idea of getting the nurses certified as life coaches, and they could be doing life coach work with some of the patients, and that's a billable service. But we haven't gotten too far with moving that forward. But we have discussed it, and actually one of our nurses likes the idea, and we're thinking about moving forward with it.
That's really exciting. And it sounds that one of the things that as a community and lifestyle that's going to be so important is developing, not having to reinvent the wheel. So if Stony Brook has tools that have been developed somewhere else in terms of how those codes work and what you need to complete in terms of the records to justify that time, and then we can move it forward. And that's one of the explorations we're trying to have in conversations. Just as an aside, we met with John Gobble from the reimbursement group, and he would probably be a great one for you and your team to meet with. That reimbursement roadmap, they're now updating it, and they're going to be updating it by profession. So that's really exciting. And then we don't each in our corners of the world have to research it and build it anew, that they're really supporting us in building that. So that was really exciting to see, yes, can bill for nurse time. So
yeah, I think that's one of the biggest barriers that we face in lifestyle medicine. Nurses are the largest workforce in healthcare. And so if we're looking to spread lifestyle medicine, nurses have the numbers to be able to do that. They're just underutilized in primary care and really in lifestyle medicine. Nurses had more health promotion education, and they had more exposure to the community setting in their education. And they had a billing code so that we could bill for undergraduate nurses, registered nurses time. Those things would really bring nurses more into lifestyle medicine and more into the community setting, specifically primary care. And that would really probably help. I think that we're really underutilizing undergraduate nurses in this setting.
Really, what you're touching on there, Maryta, is the history of nursing. That's who nurses were, always out in the community and addressing those situations that created or worked against the community and the individual and the family's health.
And nurses have been part of health promotion since the Nightingale era. That's always been it's in our blood, and primary care offices and outpatient clinics, they really operate under billable services. That's how they operate. And if nurses can't bill for their time, they really can't be in that space because they're considered a cost. They're not considered, lucrative in any way.
Can I just check in with you on challenges with your patients? What do you see with your patients when you're promoting lifestyle medicine and educating them about lifestyle medicine and challenges and ways to overcome?
So a lot of our challenges with lifestyle medicine, some of them are insurance-based. So getting people services for prevention is difficult. So we do have, if I wanted to send you to see a nutritionist, you have to have, most times you have to have an elevated blood glucose. So I can't see that your diet is subpar and then say you could benefit from really nutrition counseling by a dietitian unless you have something billable for that. There's no reason that health promotion education should only be provided once a year. And there's no reason that a person should have to have hyperglycemia or hypertension in order to receive lifestyle counseling more than once a year. So that is a little bit of a challenge. Also, the community, we have a good diabetes prevention program that's provided by our community at no cost, but a lot of the other things we struggle with. So if you have exercise is one of the most important things that we discuss often. And a lot of times, if people have not been in the exercise world, they really need a personal trainer to teach them proper form, especially our elderly and our older people that are trying to prevent and treat osteoporosis. They need help with that. And there's not a lot of money out there for these people. They have to pay for it privately, and it's really expensive. So it's a lot of financial aspects that are barriers in the community and helping these people.
Yes.
We're trying to put together an osteoporosis program now through Stony Brook. We're using our physical therapists to develop a program and hopefully build something that they can do that will be covered under insurance so that they can prevent and treat osteoporosis. But that's been a barrier for us for sure.
The ability to then educate and empower your patients and then send them on to the next step. That's really a barrier, because it's one thing to say that and for them to even say, I want to do that. But when you're talking about someone that has a higher risk for falls or has had a fall, then you really need additional support out there, and for them to just go out there and find it themselves. There are so many steps there in supporting a patient, which also gets to the role of care manager, roles for nurses, connecting MSAs, the team in that clinic, and then the time, the ability to build that out.
Yeah, it is. And that's one of the problems that we have, is getting people to be able to utilize the lifestyle route for fixing and treating these things. It usually costs money. Mm-hmm. And a lot of times, we work with the general public and the general community, and sometimes retired people don't always have financially the ability to pay for these services that they need. So it's me in the office during my 40 minutes properly demonstrating how to do a deadlift. It comes down to that sometimes, it is me showing them proper form for exercises so that they can go home and do these on their own without the added cost of joining a gym or hiring a personal trainer.
Yes, thank you. Can you tell us just a little bit about collaboration on your team beyond the lifestyle medicine, the preventive health team? If you have to send a patient refer them for cardiology, how is that working interdisciplinary also?
So because we are a large academic institution, we're actually really lucky for this. We have a messaging system within our EMR, so we can speak to other providers just through the EMR. We actually do have a care coordinator that helps facilitate our patients to find things like physical therapy, maybe that comes to the home, and helps them get their appointments with their specialists if they need it. Because we have this lifestyle medicine office, we have good working relationships with a nutritionist. We have a good working relationship with our physical therapy department where we speak to them on a regular basis. We have meetings. We're having meetings with them right now, building the osteoporosis program. So that is one of the benefits of working in an academic institution is we have a lot of contacts with people. I know that can be a little bit challenging in the community is developing those relationships with an interdisciplinary team that helps to treat the whole person.
Resources, you told us about your own resources there at Stony Brook, which we're going to be excited to highlight. But also, can you tell me, are there any others that you particularly find helpful for your patients?
Our diabetes prevention program is my favoriteest one because nutrition is one of the most important things in lifestyle medicine. It's what we really speak about probably the most aside from exercise. I would say those two are half and half. So we send a lot of people to, the diabetes prevention program is a program run by Suffolk County. It's a county that Stony Brook is in, and it's free of cost. We do a walk with a doc program at Stony Brook. Yeah. So we are involved with that. And this upcoming month, we have a walk with, I think it's the community outreach prevention person. So we do that a lot. And it's a good place where patients can ask questions and engage and find additional resources. That is also a good find for us.
That's such a touch point too. Walking together, sharing, asking, ability to walk beside a provider or a nurse, ask a question, share with one another. Those are three powerful resources that you just shared, the DPP and the walk with the doc, and then your own lifestyle medicine content and program there. Wow. Thank you. So then to the question of, in your opinion, what are key barriers preventing the wider adoption of lifestyle medicine in healthcare settings? We've already touched on the insurance, on those kind of barriers. Beyond those, any others that you think are key and how they can be addressed, and particularly relating anything to nurses or action items that any of us can do? I always feel like part of it is, well, I can't rewire the grid, but I can change what's on my plate in terms of climate change. So those types of things, maybe any action items for any of us too.
I'm also in the education sphere. So I think that we need to pull more nurses in. I think we need to get more nurses involved in lifestyle medicine, more nurses certified for lifestyle medicine. And then as a nurse, you can become certified. You can join the organization and come to our meetings, our interest group meetings. We have subcommittees that we call working groups, that we are nurses on the ground meeting, making decisions as to what we can actively do to promote this in nursing and in the community. So I think that that's on my agenda and what I've been doing. And I think that the lack of exposure for nurses to lifestyle medicine is probably one of the barriers.
Yes, just that exposure is so key, because what you found was that, oh, yes, this makes total sense, and you found it. And so the exposure, how do we get that message out to other nurses? So in terms of you are on the cutting edge in terms of the research there, you're doing it. May I ask, can you share with us, and just open it wide open to tell us about your scoping review, your doctoral work, your dreams and vision as you move forward there to help transform nursing and the healthcare of this country and the health of our people?
Yeah, so I have very big goals here. I would really like to see lifestyle medicine and lifestyle nursing courses built into curriculum. I think it's really important for nurses to get that exposure. And I think it's important in general. I think that the entire world is in a shift right now, and we're moving towards prevention. And as nurses, we need to get on that boat before we miss it. So we really need to pull nurses we need to pull lifestyle medicine and lifestyle nursing into the curriculum so that we can get nurses into primary care. And another thing that we need to do with that is to give them more exposure to the community. So nurses need more clinical rotations that have exposure to the community, within the community in primary care. I am doing my dissertation in lifestyle medicine. And if you look at the literature, there are a lot of nurse prevention clinics overseas. So there's not a lot here in the US, but in Europe, particularly Sweden has them. And they are secondary prevention clinics. So what I'm more interested is primary prevention. I want to prevent heart disease before it happens. I want to prevent type 2 diabetes before it happens. So if we look at the mapping of how they got these secondary prevention clinics, these secondary prevention for nurse-led clinics, they're totally run by nurses. In following their footsteps, I'm trying to do the same with a primary prevention clinic. So starting the research needed to show that this is feasible, this is financially feasible, this is academically feasible. So I'm starting to put the evidence out there because we can't make it happen unless the research supports it. We need to have the evidence to show that this is working. So I just did a scoping review that looks at nurse-led models of care for metabolic syndrome. And I use metabolic syndrome as a vehicle, basically, because metabolic syndrome is what the precursor to a lot of our preventable illnesses. And so I just wanted to see what was out there in the entire world. What do the nurse-led models of care look like for primary prevention? And so I did a scoping review so I could kind of take a look and see what's out there for those things. And then moving forward, we'll do probably a systematic review to see which nurse-led models work the best. And starting there, it's really exciting, actually.
Very exciting. Interestingly, with your project, when you share about Sweden and secondary prevention, it's financially outside of what's billable or not billable for insurance. Interestingly, to say that a nurse in a nurse-led clinic is now really secondary prevention. So we have established disease. So then you're saying, yes, nurses can manage that patient to that level in a primary clinic based on secondary prevention. Now we're saying, okay, let's get before that and do primary prevention. In some ways, that's almost the easier ask for the medical community to say, oh yeah, okay, nurses can do that. We're doing primary prevention, but here we have models that are really have been stood up across the ocean there. They're doing secondary prevention clinics.
Yeah. And nurses for primary prevention, it's screening and education. Mm-hmm. This is something that all nurses can do. All nurses can do vital signs and measurements that are required to see if you're at risk for this. And then we can take a look and see if they need a higher level of care, we can send them there. And we can provide them the lifestyle education that's needed. We just need to push it forward a little bit more. The nurses need the education in the curriculum to be able to do this. And then we need to demonstrate that they are in this space and they're capable of doing these things.
It sounds like a couple of things. So one, the education, can we touch on that, go dig into that a little bit? What would you, if you had a magic wand, what would you say? We have the new essentials now that's coming in, and that's really looking at root causes of disease across different levels of nursing. So whether you're at a bachelor's level or doctoral level, we're talking about, insulin resistance and inflammation, sort of these. So it's getting to the root, which is exciting. I know one of the pushbacks in nursing is the curriculum's already full. There's no space. Could you tell me in your dreams what you think should happen, would happen, could happen, and what you think any of us can do to advocate? So kind of touch on those things.
Yeah. So curriculum changes are actually really difficult. They tend to lag behind the clinical changes that need to happen. And we do in the academic world suffer a lot from content saturation. What we need to do is move to a more concept-based curriculum for the academic world, meaning we're going to talk about the concept behind the disease. And when we do that, we're going to talk about the life on a continuum. So we're going to talk about the concept of insulin resistance from the start all the way to the end. And when we do that, we can spend enough time on the prevention area of that. And so the curriculum needs to go through some pretty drastic changes in order to meet this need. But I think it will get there. It will get there. It just takes a lot of training, and it's revamping the entire curriculum, and it tends to be a little overwhelming, and that's why universities are slow to do it. But it's happening, and it's gonna keep spreading. Yeah.
Wonderful. It sort of goes to that Ornish's the unifying theory of disease. You're working with metabolic syndrome. It's there underlying, whether it be cardiovascular disease, diabetes. Can you give us a really exciting story coming out of that when you say it's already happening? Can you paint a picture of something that's happening?
I actually don't have too many stories of it other than what I do in my own personal classroom when I'm teaching. And so clinically, when I'm teaching, I tend to teach on a more concept level. So for nurses, for example, if I'm teaching sterile technique, I basically teach the nurses what's clean and what's dirty. And then I teach them to use that concept across all of their procedures. So I can say, okay, you're putting in a Foley catheter. I want you to tell me what's clean and what's dirty. And okay, you're going to do suctioning. I want you to tell me what's clean and what's dirty. So if they understand the concept of what's clean and what's dirty, they can carry that through multiple procedures. And that's basically what concept-based education is about. Anecdotal perspective, it works really well. I could see the students thinking before they do and understanding why they're doing it instead of memorizing steps.
Yeah.
And it works the same with the disease process.
Yes, how beautiful. Florence Nightingale said, step back, be curious. What are you seeing? And so I just got chills as you told me about that, because that empowers the nurse in a situation where I haven't seen this before, but let me step back. What's clean, what's dirty, what's sterile, what's not, and just applying that, building those critical thinking skills, the discerning skills, empowering our nurses to say what looks healthy, what's not, what's in it, what's not, and on, expanding that. May I ask, what would you like to see happen like as passionate lifestyle medicine ACLM members and nurses? Are there some other things that you would love to see us doing out there with all of this?
I do feel like I'm on the ground with you guys, and we're working as fast as we can and doing all that we can. But right now we're currently trying to reach out to universities to kind of make contacts and talk to them about what lifestyle medicine is and trying to get it into the curriculum. And like we spoke about before, I've reached out to the Stony Brook School of Nursing, made some contacts over there, and I'm going to start a lifestyle medicine interest group in the School of Nursing. So starting interest groups in schools of nursing, I think that's the approach that we're currently using. And I think it's a great one to get early exposure. And I think specifically for nursing students, one of the other perks that's really important about lifestyle medicine is the health and the wellness of the nurse. Teaching student nurses how to be healthy for themselves helps them to understand how it works. I live a healthy lifestyle. I exercise regularly. I eat a whole food diet most of the time. And so I'm able to share with my patients my own trials and tribulations, my own difficulties, my own barriers. And so if we can get nurses to be healthier, they will not only will they be a healthier workforce, but they will also be an example and be able to share that with their patients, their own personal stories of how the difficulties and the barriers that they faced in their own lifestyle.
What you've described is sort of a three-pronged approach and then more, but three key tools is from the ACLM and the working group, doing direct outreach to the universities, the work with the networking committee, and doing direct outreach to the university at that level. Then from within the LMIGs, the lifestyle medicine interest groups, to get that going there. And then nursing student herself and himself is that whole aspect of living it, the self-care. How do I take care of myself? Oh, I get it. And then the concepts that you've shared so beautifully about coming at it from the concepts. And then, of course, the empowerment to share, because when we live it, we want to share it and we know how to. And we are also able to understand and appreciate those barriers and appreciate them from our patients too. So we've come through so much. I guess what I'd love to ask you then is when you look at the future and your ongoing initiatives, we've talked about some of these things, but to just say what else you might like to share. We had spoken about the future of nursing, the National Academy of Medicine future of nursing, and sort of almost coming together on those two things, the power of lifestyle medicine to address social determinants of health. And that you're already thinking and working in that space and all your work there. So a long-winded question that we'll edit out, but just a big entree to say, just open it up and tell what you're doing, what you see, where you think the Academy report emerges, and how there might be synergy between those two, and how we might be able to link these communities, these great thinkers together more.
I think what we need are more lifestyle tools that incorporate the social determinants of health. So when we are trying to institute behavior change, because I think at the crux of lifestyle medicine is behavior change, our patients and people are limited by their environment. Their social determinants of health are a huge factor in whether they're going to be able to institute these changes. So the tools that we use to measure and to encourage lifestyle changes need to come from a place that really acknowledges the social determinants of health. I think we need more tools like that. We have, if you look at our behavior change tools, like the theory of the behavior change theories, they need to incorporate more social determinants of health.
Okay. So
we
beyond
need to assess
pages of
people only have access to what's in their social and political environment. And we need to use our behavior change tools to reflect that.
Sort of an upgraded model of procrastination. It's one thing to look at where is someone on that trajectory, but also how do we then build in and address and tools for assessing and then supporting someone within once we determine what those barriers are for that individual. And as clinicians, as nurses, I think what you're saying is that needs to be a bigger part of the content material tools, both for assessment and for empowerment and education of our patient, even to the point where when you say get down to the root cause, we're talking about so that patient is even aware, just some self-awareness, so that we can then dig in and find out what resources there might be.
Right. What resources they have. It's helpful for us to understand that a patient wants to change. Let's say they want to move to a whole food plant-based diet, right? So we know that they want to. We can assess their stage of change. We can assess how motivated they are to change. But what we need to assess is what's their access to whole foods? How are they going to get to the supermarket to get these foods? Do they have the financial means to buy these foods? So it's looking at things like that. What is their culture like? Does their culture and the foods that they typically eat, are they incorporated in this whole food plant predominant diet? So it's really taking a look at their social circle and seeing if they have the access to the tools that are necessary for them to be successful in this lifestyle change.
Can you give an example of anything like that you've seen that's developed that you'd want to see more of at all? Or this is what you're finding is there really isn't much and we have a lot of work to do?
I think that we have a lot of work to do. There are like Pender's, Nola Pender came up with the health promotion theory. She does touch a little bit on the social aspect of it, like a person's support system. But I think that we do need some behavior change theories that really focus in a person's social circle, their social support.
And therefore, if that's the case, then this is another ask for our nursing education is that to build in more about that behavior change. And again, I wanted to see if we could take a minute to circle back to the nurse and the nursing student. But that's a key one, the behavior change for that in the education, the nurse working with at all levels of nursing, working with that patient and being informed by that, just like you say, if they know what's clean and not clean, wow, what helps and supports someone in their behavior change, the Pender theory and the procrastination. So then in terms of our nursing students and our nurses, beyond that education for our patients, can you speak to what you would love to see for our nurses? That's such a big issue right now, is nurses leaving the profession due to COVID and what they experienced and the burdens of the understaffing and being able to really transform nurse self-care. And that's bigger than what any nurse should be able to do. That's the system itself. And then also bringing it from kind of raising nurses that way from school in the nursing education that they receive that you're already building in.
Yeah, I think that nursing students need to learn how to take care of themselves first. Mm-hmm. I do. I think they need to focus on their own wellness, their physical, their emotional health, because a lot of times they suffer from burnout and they need to be able to recognize those signs and symptoms of burnout so they know when they need additional help. And I think that lifestyle medicine is a good way. If we introduce them to lifestyle medicine, it kind of incorporates all of that stuff into one. It really includes your mental health, your social support system. It's included in there. So I think that sharing that with nursing students, it really helps them to understand that their health and their wellness is just as important.
And somehow that's really beautiful, and somehow creating that space for them to do that. I think that's going to be incumbent upon our nursing educators and our nursing and education institutions, is not make it another task or ask for our nursing students, who are the ones that are in the library at night when everybody else is out. Well, but other students might be having a little more free time, but we know where our nursing students are. But actually creating space for them to do it, just as you're able to see those students processing it, to live it and do it. And then they'll move forward as lifestyle informed nurses, nursing students, and advocating for themselves for that self-care in when they go to a work setting, to be their own advocates.
Yeah.
Thank you. Is there anything else you'd love to share with everyone? And knowing that we'll be tightening this up and editing some of my long-winded questions here. Everything you said is so beautiful and important, but any last thoughts, either on a small level, like a little beautiful nugget, or on a big global dreaming level, or anything in between?
I think that I just have a special place for nurses in my heart, because I've been a nurse for so long, and I just want them to believe in themselves as much as I believe in them, and that they are capable of really creating change here, really being a part of this health promotion and preventive health movement.
Thank you so much for that, Maryta. And thank you for being a part of moving nurses in that direction, empowering them, giving their voice, giving them that insight. So thank you so much. And thank you for this time together.
Thank you. Thank you for all of the work that you're doing, trying to push this forward.